Hello, everyone, and welcome to the January meeting of the Global Health Youth Organization. My name is Noraldine, and I'm a co-founder of the organization. We are very excited to see everyone who joined us today, and we want to thank everyone for joining the meeting and working around any scheduling or time zone issues that you might have had. As for the format of today's meeting, we will begin with a quick introduction of our speaker, followed by his presentation, and then a question and answer session. After the Q&A section, we will post a shadowing certificate link in the chat, and we ask that all members stay muted throughout the presentation so that we can limit interruptions and distractions. Please feel free to add any questions or comments that may arise in the Zoom chat. I'll now be passing it over to Adam, the other co-founder of the organization, to introduce today's speaker.
Thanks, Nor. Hello, everyone. And as Nor mentioned, I'm a co-founder of the organization. It is so great to see all of you that joined today, and we are happy that you are able to attend this meeting. We want to once again thank Dr. Anton for taking the time to present today. To quickly provide an introduction, Dr. Anton is an interventional radiologist at Thomas Jefferson University. Dr. Anton will primarily be speaking on his work on global radiology and improving health outcomes in low and middle income regions. Please remember to stay muted throughout the duration of the presentation to minimize distractions. Again, if any questions do arise, please type them in the chat and we'll get to answering them at the end of the presentation. With that being said, we will now hand the floor over to Dr. Anton for his presentation. Thank you.
All right, guys, thank you both. I appreciate the intro. Let me share my screen here. You guys can see that okay? Okay, cool. So first, let me just say that the fact that this organization exists and you guys are here participating on a holiday Sunday to hear somebody like me talk about global health is impressive. So honestly, the honor is all mine. So happy to be here, and I hope you guys enjoy it. So like we talked about, so we're going to talk about global health radiology, specifically looking at how myself as an interventional radiologist is involved in what we're doing. So I'll get through here. So a couple of disclosures, just so you know, kind of a little bit about where I'm coming from. So I am an interventional radiologist at Thomas Jefferson. I am the associate director of IR at Rad8 International, which is a nonprofit radiology outreach program that is essentially looking to expand radiology to low and middle income regions throughout the globe. So I am director of the Rad8 chapter at Jefferson, as well as I've started the Global Radiology elective for the radiology residency at Jefferson. And more importantly, I love what I do most days. So if I happen to be able to inspire one of you to stick with healthcare and global health, then I've done a good job here today. So we're going to talk a little bit about interventional radiology, because I'm going to assume that most of you probably don't know what it is. We're going to talk a little bit about where we stand globally, what some of our IR initiatives are at Rad8, and then if I have time, I'm going to talk about one project that we're working on that'll give you kind of a good circle back to how all of this is kind of interacting together. So just a quick little intro about me so you know where I'm coming from. So I was born and raised in New Jersey. I did my undergrad at Penn State. I went to Rutgers for medical school, did my radiology residency at Geisinger in central Pennsylvania, and then did my fellowship at Thomas Jefferson. And here we are. So I'm just going to give you a brief intro to IR through a video. So if you can't hear this, just let me know, but I think it's going to work.
Interventional radiology is essentially minimally invasive image-guided surgery. So interventional radiologists are a unique sort of set of clinicians that have various skills in essentially making a pinhole size incision in the skin to reach various organs in the body to deliver targeted therapy. There isn't a specialty in the hospital that interventional radiology doesn't have some involvement in. Interventional radiologists do a whole host of procedures, operations on the arteries. If the arteries are blocked, they can unblock them. If there's any bleeding in the body, they can access it and stop the bleeding. There's various procedures they do on veins. We are now able to treat stroke as well. Cancer therapy is also another big part of interventional radiology. So they also offer a whole range of standard procedures for routine conditions in women, for example, who have uterine fibroids, men who have prostate problems, or if you have any musculoskeletal or bone-related problems, again, there are procedures that we can offer. Interventional radiologists use a selection of equipment including X-rays, ultrasound, CT scans and even MRI scans to guide their treatment. There's often no general anaesthetic involved, so most of them are performed under local anaesthesia or even with light sedation. So in comparison to conventional surgery, the risks of general anaesthetic is also taken away. Most of the procedures are done through a very small incision as opposed to a big incision. The complications after the procedure are far less. The recovery time is quick. Patients only stay in hospital for a very short amount of time. Most of the procedures nowadays are actually offered as a day case, so they're treated as outpatient. They come in the morning, have their procedure done, and they can be discharged later on in the day. I invite you all to look at the patient information section on the CERSI website to find out what interventional radiology procedures we offer and what conditions can be treated by interventional radiologists.
All right, guys, so just a very brief overview about what interventional radiology is. So again, minimally invasive treatments throughout the body, essentially. And like she said, there's really no part of healthcare or hospital care that we don't interact with. So just to give you a sense what a typical day might include for somebody like me, you know, you might come into a Monday and your procedures for that day, you might place a chest port for chemotherapy access for somebody with cancer. Your next case might be radioembolization or internal radiation for a person with liver cancer. The next case might be a uterine fibroid embolization for a woman who has pain and menorrhagia or bleeding from fibroid disease. Next case might be a dialysis fistula that's clotted off and you need to open it back up, an abscess drain placement, tumor biopsy, or an embolization for a trauma to stop a bleed. So the next day might be a peripherally inserted central venous catheter for IV antibiotics. You might be freezing a renal cell cancer. Your next case might be a prostate artery embolization for an older gentleman with benign prostatic hyperplasia or BPH. So I'm not going to read all of these, but you can see that the nice part about interventional radiology is while most of us end up subspecializing to some degree and kind of becoming experts in you know, a smaller subset of some of these cases, most of us still perform the majority of them. And so every day is different. Every day is a little bit more exciting, and depending on what kind of traumas and more acute care comes through the hospital that day, you kind of never know what you're going to get. So definitely worth checking out when your time comes to get there. Just to give you a little bit of brief history, so over the past 10 years, we've actually become our own specialty. We prior were a fellowship out of diagnostic radiology, but because people started to see just kind of how much we're doing, we've actually become our own residency program. So you come out certified in both diagnostic and interventional radiology, but you're applying essentially to the interventional radiology residency program, which is a 6-year program after medical school. And then oftentimes our first intern year is going to be a surgical internship at this point. So just again, to give you a little brief history about me. So I did my Thomas Jefferson fellowship in IR. I took my first job at the University of North Carolina down in Chapel Hill. Here you can see the medical center. And here's where I met two people who were kind of instrumental in moving me into global health. So this is Bob Dixon and Melissa Culp. Bob Dixon is an IR who's just transitioned over to the University of Arkansas. And they were big into global health and rad aid, and they essentially got me excited. So this is my plug for mentorship. So you guys are obviously already doing the right thing. You're interested enough to have started an organization, and you're participating in some of these webinars to get an early sense for what you may or may not want to do. So find that mentor, find somebody who speaks to you, find somebody who's excited about what you're excited about, and let them help you kind of get you to where you need. So obviously mentoring has a lot of support and reasons to get involved early. Obviously this person needed a little bit of mentoring and spelling, but yeah, the point is there, right? So you continue doing what you're doing. So when I was at UNC, so this is Dr. McGinty. She is a body radiologist at University of North Carolina. Here you can see her with a group of radiologists in Malawi. And so there was two regions that UNC, with the support of RadAid, was focused on. One was Malawi, predominantly for diagnostic radiology outsourcing and support, and the other one is in Nairobi, Kenya, and we'll talk about both of those a little bit more as we go forward. So here, just to show you, so this is at University of North Carolina, and we had a couple of radiologists from Malawi come and spend some time with us. Here you can see Bob Dixon hiding back there. So this was one of his trips to Kenya. And again, we're going to go into these trips a little bit more, but one of his outreach trips. So I took a trip back from North Carolina to Jefferson for family reasons. And then I kind of used what I learned at North Carolina to start the Global Health elective here at Jefferson. Specifically because I wanted people to have opportunities to get involved. And I wanted, our trainees, our residents, our medical students to be able to make these trips with us to help support the programs elsewhere. So let's talk about global radiology a little bit. So global radiology resources. So we know that about half the world lacks access to radiology services. But we also know that about 50% of medical conditions rely on imaging for proper diagnosis. So there's obviously a balance issue here. Ideally, you would want 100% of the world to have access to radiology. If we look at IR specifically, or interventional radiology specifically, here you can see, just to get a sense, so Tanzania has a population of 60 million. And at the time, there were 0 IRs in country. There's been a lot of work on this recently, and so that number should be increasing. Kenya, with a population of 54 million, has 10 IRs, and we'll talk about how this is growing. Vietnam, again, about 100 million people, 150 IRs, and if you compare that to the United States, really we're talking about somewhere between 3- and 5-fold of these, but our numbers of interventional radiologists are much higher. So obviously our resources here are more significant. What we know is that interventional radiology has proven to be cost effective and decreases morbidity and mortality over traditional treatment options. And this has been shown in high income regions. But we also know that there's underutilization in the low and middle income regions. So how can we improve that and expand our services elsewhere? So this is going to give you a kind of a bird's eye view of the RadAid IR program. So again, RadAid is a nonprofit organization looking to provide sustainable radiology resources throughout the world. So the goals of our program are obviously to increase access in areas that don't have access, to also increase awareness so that a lot of people in the United States still don't know what IR is. And so obviously globally, that's going to be a big challenge as well. And then where the majority of our focus is right now is to develop dedicated training programs, right? So the part of the sustainability component of it, right, is we don't want to make a trip 4 times a year, provide 2 weeks of IR services during those 4 trips, and leave and then have no IR services there. So, right, we want to be able to develop programs so they can train in country IRs who are going to stay there and practice there. And here you can see some of the sites that we're working in. So Kenya, Vietnam, Ghana, Nigeria, Ethiopia, and we're expanding into Indonesia as well. Again, I'm not going to read all this. So obviously there's challenges in providing global training, whether it's radiology or interventional radiology. There's social challenges, infrastructure, logistics, political and administrative challenges. And so overcoming some of these can be challenging sometimes. Some of the process can be painfully slow, but obviously our goal is sustainable, right? So sustainable efforts that are going to last and still provide benefit once we're not there. So a lot of people have this kind of vision of this aha moment, right? So this is what it's going to look like when you make a trip globally. And then when you actually get to the hospital, they tell you that this is the reading room for the radiology services. And this is what you're starting with. So this is obviously not a real picture, but we've seen plenty of pictures and stories about rooms just like this, that this is where the first radiology room is going to be. So Rad8 has kind of created a pretty standardized system for how this all begins, right? So anytime you go to a new location, a new hospital, a new country, that hospital in that country or that specific health facility is going to be at a different starting point, right? Some are already going to have an X-ray machine and a radiology department of some kind. Others are not even going to have, right, the electrical capacity for that yet. So part of the first step is to understand where they are and what the most urgent needs are going to be for that population first. Once we have that all set up, we start deploying teams to help. And so we take a very multidisciplinary approach. Obviously, it's going to be physicians, trainees, nurses, technologists. A good majority of it is didactics and teaching. And obviously, we're working through collaboration. So we're trying to bring best practice to their practice. And so this takes a lot of relationship building. And again, collaboration and just understanding that different regions do things differently. And then COVID happened, and kind of all things came to a halt, and deployments are on hold, and we've had to transition a little bit to how we're educating. And so a lot of what we've done is try to figure out how we're going to educate, how we're going to collaborate, and how we're going to create this sustainable relationship through virtual, right? So we've used a lot of different techniques, whether it's learning modules, simulation, webinars, symposiums, virtual reality, to try and continue this teaching, and we'll kind of walk through some of that. So one of the big things we use is simulation, right? So a simulator allows the trainees to get familiar with the type of equipment that they'll be using intra-procedure. They get to learn some of the key steps without hurting anybody, and they get to just practice their skills in, again, a risk-free environment. So when we talk about low fidelity simulation, these are gelatin molds that we've created, so someone can stick an ultrasound probe in a needle and get comfortable with ultrasound. And then high fidelity simulation, where you're actually stepping on a fluoroscopic pedal, you have a wire and a catheter in the simulator, and a screen showing you kind of where you need to get to and showing you how you're getting there. Before COVID, we were using the simulators a lot. So Mentis has a high fidelity simulator that we've brought globally with us as we go to different sites. Again, here you can just see different. So this is in Kenya, and here you can see them working with the simulator, teaching through the simulated cases. So it's a great way for hands-on collaboration and teaching. And obviously, here you can see kind of how everyone gets into it. But again, if you can't get there and you can't bring the simulator because your travel is grounded, then we've had to switch gears a little bit. So we've tried to combine didactics with online simulation, right? So we do live cases where which one of us has the simulator at the time, we're performing the case and we're all talking through it, and we got a good kind of discussion going of how we would perform the case, and then get good question and answer and break out from the trainees. So that's one way that we've kind of transitioned, but really what I wanted to focus on more is kind of what we do. So here you're going to get a quick look right into some of these programs. So here in Da Nang, Vietnam, we have a site, and so here you can see them helping to perform the first CAT scan guided biopsy in Vietnam. This is Andrew Kesselman. He's one of the interventional radiologists at Cornell, giving a talk on ultrasound guided biopsy. This on the top right, you can see the radiology residency class in Vietnam. And obviously in the bottom right, you see Dr. Kesselman going through some case review with one of the interventional radiologists at Vietnam. So this is kind of what a trip might encompass there. Here you again see them looking at some images on a light box. Here you can see them in the single IR suite that they have, and then same thing. So in Ethiopia, here you can just see what kind of what the setups are. So they have on the left, again, a single IR suite that you could do some of your more complex procedures in. In the middle, they have a C-arm or just a portable X-ray for some lower level procedures, an ultrasound machine. And then on the right, you see one of the RAD-aid nurses training some of the nurses in Ethiopia. So again, very multidisciplinary. We're teaching IR trainees, we're teaching IR physicians, we're collaborating with them, we're teaching nursing, we're teaching technologists. And so it's kind of the whole gamut. In Lagos, Nigeria, same thing for the most part. So this is Stephen Hunt. He's one of the IRs at University of Pennsylvania, who's giving a talk and going over some questions. So a lot of education, same thing. Educating is kind of the big thing here. In Nigeria specifically, Dr. Nina Lowo, who was a University of Pennsylvania graduate, he has since worked with RAD-aid in Nigeria, has decided to go back to Nigeria, and is now one of the only practicing IR docs in Nigeria. But he's very active on Twitter and LinkedIn, and kind of just showing some of the work that they're doing in Nigeria. So this was just from January 1st. You can see that they're traveling all over the place to help with emergencies, to try and again build up the service in Nigeria. So very interesting to watch kind of what he's doing. And we're working with him now to set up a training program in Nigeria through his IR practice. So more to come in Nigeria. Like I talked about before, so Nairobi in Kenya, this is kind of where our greatest success has been so far. Here, just a couple pictures. So this is Dr. Dixon again, performing an ultrasound guided procedure with them in Kenya. What we've done in Kenya is we've actually, so we've taken their radiology residency, which has 54 residents in it. And since a few trips, we were doing didactics, case-based reviews. This was a trip. This was Clayton Commander, who was a UNC or University of North Carolina radiology resident at the time. He's now a practicing IR at UNC. You can see him giving didactics. Over a couple of years, you can see some of those pictures from the trips. Kenya has a single Philips IR suite that they use. They do approximately 1,400 cases per year. and really a wide range of cases. It's actually quite impressive how variable their treatment is. But they still struggle with logistics of equipment, the machines going down, not having the stent sizes that they need for a certain case, equipment. So it's still a big work in progress. In 2019, here you can see this was pre-COVID. So obviously people were getting their hands on the simulator. They were interacting without masks, going over cases. This was a first timeout. So a timeout is a pre-op procedural checklist to make sure that you have the right patient, the right procedure. You're not going to do it on the wrong side of the body, kind of all that stuff. And they had never done that before in Kenya. So again, quality improvement, and obviously chalk talk up in the top right there. So here you can see this is Dr. Dixon. This is Dr. Mugabe, who is the lead IR at the University of Nairobi in Kenya. And again, there is time to kind of go off the beaten path and do something other than work and enjoy the trip there. So to give you a little bit of a sense of kind of what we're looking to achieve in Kenya. So when I talked about that readiness assessment through RADAID, where we kind of decide where the program is starting from, that was completed in 2018. You saw some pictures from 2 in-country visits in 2019. We had a fellowship curriculum approved in June of 2020. We've been doing annual IR symposia with the Kenya Association of Radiologists in Kenya. So we've started the first IR fellowship in Kenya. The first 2 fellows started in September of 2020. They will graduate in August of 2022. A second round of 2 fellows began in 2021. So they currently have 4 total fellows. One of their senior fellows is coming to join us at Jefferson in May. So they'll be doing some observership in the United States as well. And obviously our goal is to double the number of in-country IRs by 2030. And this is that sustainability component. I think I have a little bit of time left. I don't want to go too far, but I just wanted to give you a little bit of a look of kind of how we're using IR practice, research, and combining it all into kind of a global radiology look. And this is looking at postpartum hemorrhage. So bleeding after giving birth, and how can we help? So postpartum hemorrhage. So this again is the leading preventable cause of maternal illness and death globally. If we look worldwide, it accounts for about 8 to 10% of maternal deaths in developed regions, 20% in developing regions. And if you look on the right here, again, it's a big problem, and we don't want young women, dying for no reason. So this problem is known about. There are organizations out there trying to help, but if we look on the right side here, just to give you a sense, so it is a problem, but 99% of postpartum hemorrhage deaths occur in resource-limited settings. And so while it's a problem here in the United States as well, it's more of a problem globally. And so the question is, how can we help to fix that? I'm gonna try and show you one more video here. I'm not gonna let the whole thing play through, but.
In Kenya, we continue to record very high maternal mortality, and number 1 killer is postpartum hemorrhage. We have seen women going to hospitals and not coming back. And we have seen midwives just stopping to conduct deliveries because of their experience with postpartum hemorrhage. It is a scaring moment when a woman starts bleeding after delivery.
We started with uterine balloon tamponade, UBT, 10 years ago. There are a couple of reasons as to why it's not found everywhere in the world. The first reason is that there just aren't enough people on this earth yet that respect women the way women deserve to be respected, and that put women's health and survival as a priority. The reality is, it remains the biggest health disparity on earth, which is the survival of women when they become pregnant in poor countries versus the developed world versus wealthy countries. It's fairly clear that just dropping in and sprinkling uterine balloons around all by itself doesn't make a difference in saving women's lives. People need to be trained. People need to be rewarded for saving a life in whatever way is appropriate for their context. People need to have interventions integrated into their care. They need to have supplies, whether it be uterine balloon or anti-shock trousers, they need to be available. So systems are really lagging behind when it comes to what's necessary to save women's lives.
One day, one of my resident, along with the senior resident, they operated a case. They did cesarean section, and they said that, ma'am, we have closed it. We are very sure about the angles, but patient is bleeding suddenly, and I rushed. By the time I reached there, it was as if, you open a tap, and that kind of blood was coming out, and uterus was totally atonic. When I came, I looked at the anesthesiologist, and there's a way to tell, not to let anybody else know. Means no blood pressure, no pulse. So then all I remembered was Dr. Burke's balloon at that time. So I just got that balloon and I inserted it out of desperation that I have to save this woman. 500 cc, I realized that the bleeding is reducing. And I just want the bleeding to stop completely, because I was sure that if I don't stop it, she's going to die. So then I kept inserting. This is the highest fluid I have inserted in my first case. So 800 ml and bleeding ceased. And then anesthesiologist was very happy, pulse is there. And this felt like a miracle to us,
So that just gives you kind of a look at how big a problem this is globally. Now, obviously, from an interventional radiologist standpoint, we're not inserting the balloon that they're talking about, right? That's the OBGYN or the surgeon who's there to help kind of tamponade and give us time. From an IR standpoint, we treat postpartum hemorrhage through either a pinhole incision in the wrist or the groin, and we work our way into the uterine arteries with small catheters and use particles of kind to plug up those vessels that are bleeding. And so we believe that awareness of IR services, availability of IR services will be able to decrease morbidity and mortality in postpartum hemorrhage in women by giving them definitive treatment of the bleeding, but also allowing them to keep their uterus. So oftentimes these women will be rushed to emergency hysterectomy for the uterus to come out, and then obviously they can't have children anymore going forward. So one of the ways we're looking at this is to try to better understand the postpartum hemorrhage landscape. And so one of the ways we're doing this is through geographic information systems. So you've all seen these maps somewhere at some point. You can build layers. So anytime you look at a weather map or a map of a landscape, it's built based on data layers. And we're using this to try and get a better understanding of how we can perform radiology elsewhere. So this, just to give you a sense, this is a mobile airship that RAD8 is working to develop to be able to transport radiology to places that can't get to hospitals quickly. an airship like this might have a CAT scanner on it and a few ultrasound procedure rooms, with the idea that if we can land this airship in a place that people can't get to a hospital within 6 hours, we can do some good. And so part of the GIS part, or the geographic analysis, is understanding the landscape, where we can land it, but also understand the population and where people are at the highest risk. So using a health severity index to see kind of where the hottest spots are for people who need help, and understanding where we can actually land an airship like this. So we're using a similar question and similar technique to try and look at postpartum hemorrhage. So can we use this to better understand the postpartum hemorrhage landscape? And we're looking specifically at Kenya, as well as the state of Georgia here in the United States. And so, right, the hypothesis is that availability and awareness of IR intervention, specifically with uterine arterial embolization, can impact maternal mortality, decrease emergency hysterectomy rates, and improve maternal morbidity. So again, this is our pilot project. It's a collaboration with University of Emory down in Atlanta. And I'm not going to get too much into this, but again, can we better understand the demographics? Can we better understand the populations that are at risk? And can we better understand where the accessibility is and kind of where it stands? So you get a sense for some of these maps, so you get a feel for like where the healthcare facilities are, the little red dots, and you can get a sense for kind of, this is not specific to the project, but you can get a feel for where the population is and where the overlap is. So the goals of this pilot study are to identify the trends in this postpartum hemorrhage landscape, and see if we can improve them. So here's a look at Kenya. So we can map out kind of where the women are of maternal age, and kind of where most of them live. You can get a sense for where they're dying, and see where should we be targeting to get the kind of most impact. And so what we're going to try to do is develop a similar health severity index for maternal age women, get a feeling for where they are, how far they are from a healthcare facility, where is the closest healthcare facility that can potentially provide radiology services, and then can we target our training, right? So can we focus training for the IR fellows to then go out and form a practice in a region that can potentially benefit and save women in that region. And so this is just one project we're working on, a very early stage, but you can kind of see how it all comes together, and you can ask some kind of important questions that can potentially help a lot of people around the world. So just some take-home points from the RAD-8 IR portion of the program. So obviously we're dedicated to increasing awareness. The goal is always to provide a sustainability, and so building the infrastructure so that they can continue to provide services is paramount. And then obviously there's opportunities to get involved at all levels. So whether it's residents, medical students, people from your organization who are just interested in learning more, don't be afraid to reach out to mentors and people who are doing something that excites you, because you can probably get involved already. So again, mentoring, kind of as you get through your training and decide what you want to do, you're going to make your decisions based on what's important to you, and hopefully being in this organization, you won't forget about global health as you come through yourselves, whether it's to be involved through collaboration or to start your own projects and programs. Keep doing what you're doing. And obviously I have a lot of collaborators and a lot of people that I need to thank. I'm not going to talk about them here today, but just know that this is not something you do on your own. So get involved, stay within an organization, find people that you really gel with and kind of enjoy picking each other's brains and asking each other difficult questions. But thank you very much for being here, and it was honestly a pleasure.
Thank you so much for the amazing presentation. We really appreciate it. So if it's all right with you, we will now begin the Q&A section. We're going to first start with the questions that were asked through the registration form, and then we will get to any questions that were asked in the Zoom chat. This is your opportunity to ask questions, so please ask whatever you have in your mind. So I'm going to hand the floor over to our board member, Mark, to read the questions that were asked through the registration form.
Thank you, Adam. So the first question we have down is, how does radiology impact the younger generation?
So I think it's an interesting question. So radiology obviously impacts everyone at this point. There's really very few diagnoses in medicine nowadays that don't have some sort of imaging, to help with diagnosis, to help with treatment. And so I think whether it's the younger generation or the older generation, radiology is important. And obviously, it's not cheap, right? The radiology equipment, radiology services are expensive, and so I think our goals are to figure out how to implement everything in a cost-effective way, and again to expand that to the rest of the world.
Thank you. So the next question we have is it might have been discussed a little bit, but in what ways can we make radiology accessible to lower income countries and/or cities?
Yeah, again, I mean, it's kind of what we've talked about. RAD8 is just one group who's doing it, but does it really well. It's really just finding the group to help. Understanding that there's a lot of places that just aren't ready for radiology yet, and it might be political, it might be infrastructure. But what we do know is that you can't just drop a CAT scan machine off at a hospital and expect it not to end up sitting in a back room just collecting dust. So it's not easy to just donate equipment. You have to find the infrastructure to utilize it appropriately, the physicians to read the studies. You have to sometimes get the patients to understand that it's not going to hurt them, and obviously find the technical components. So you need people to care for the equipment, keep it running, maintain it, know how to run it. So there's a lot that goes into each install, and obviously keeping radiology running on a day-to-day basis takes a lot of money.
Well said. So the next question we have down is radiology sustainable?
I think if you do it correctly, it is. It's not that every program we start or try to help, runs long term. Obviously, we run into situations where we start a program and it either stalls or something goes wrong. But sustainability and kind of starting from that thought process that whatever you're doing, you have to put in place in a sustainable way is probably the most important concept.
Thank you. So the next question we have down is, how should we dissolve any stigma towards radiology in the medical field?
So this is a little bit difficult. I guess I'm not exactly sure what stigma we're talking about, but I think just education alone. So I think a lot of people in the medical field, as in the older generations, kind of view radiology as just a service where just read the study and for whatever order we put in. I think we're slowly changing that. I think interventional radiology has expanded that quite a bit. I mean, we are, physicians who see our own patients in our own clinics and treat people from head to toe. So, radiology is kind of expanding in terms of what it can do and how we can care for patients.
Thanks. So you kind of talked about how you went into why you chose global health, but why? The next question kind of says, why did you decide to go into the specific field of interventional radiology?
So I was lucky enough. I did a rotation in interventional radiology as a medical student, as a third-year medical student. Had never heard of it before, and just kind of saw how interesting it was. So you shadow, you put your lead suit on essentially, and headed to the room to see what they're doing, and just fell in love with it. Every day is different. It's challenging. It's frustrating. Some of the procedures you walk in and take 15 minutes. Other procedures we do, you're kind of working through problems, and you might be in there 6-7 hours. And so every day is different. It's exciting. It's a lot of fun. There's a lot of innovation in IR. We're always creating new procedures, new medical devices, kind of new ways to do things. So I think it's probably, I'm biased obviously, but I think it's probably one of the coolest medical specialties you can get into.
Yeah, it's a really important part of any career is that you really enjoy it and that you really find joy in it. And this kind of just flows perfectly to the next question. So what would you say brings you the most joy in your line of work?
So like I said, most of us are relatively broad in terms of what we do, and then kind of subspecialized to some degree in some niche of IR. Mine happens to be oncology, and so I would say my greatest passion is treating cancer patients. So if I can take a patient with a liver cancer and kill that cancer and get that patient to be able to survive to the point where they get a new liver for a liver transplant, and then obviously go off and live the rest of their life, then I've done a good thing.
Thank you so much. So those are the questions that we had previously. So now we'll go into the questions that were in the Zoom chat. So one question we have here is, why do you think that the US developed in the field of IR faster than other countries, specifically in Asia and Africa?
So the US is definitely expanded faster. Again, I think the great majority of it is financial. We just have the resources to grow and push that many IRs out into practice. I think that the US probably still has room to expand, and so continents like Africa and countries within Africa have a long way to go, but at the same time, their starting point is from a different. They have a different starting point. So I think most continents should be probably providing IR services at a similar number to the US. It's just there's a lot of money in academia. There's a lot of money in the private industry in the US, and then putting that emphasis on healthcare and quality of healthcare in other places is just a little bit slower.
So thank you so much for all those great answers. That was all the questions we had for today. So we want to once again thank Dr. Anton for taking his time today to give us an introduction to his research and his work in radiology. And thank you all for attending today's presentation. Please use the link posted in the chat to obtain your shadowing certificate. And thank you all so much for attending, and we look forward to seeing you in our next monthly meeting. But we will stick around for a couple of minutes to make sure everyone has access to the link.